So here we're going to walk through cerebellar anatomy. This is going to be our general layout, which is going to allow us to learn about these different cerebellar modules. We're going to start with this gross cadaveric section with myelin staining. It really emphasizes the idea that the cerebellum has these folia that allow it to pack really densely into the posterior fossa. We can think about the fact that the cerebellum is argued to have more nuclei than the rest of the cerebral cortex. Its key manifestation is modulation of movement and then adaptation and learning. So this is a sagittal illustration here. We can see the anterior lobe, posterior lobe, and then the flocculonodular lobe. But then what we're going to do is we're going to create this dysmorphic cerebellum. We're going to flatten it out and really adjust its layout in order to learn these modules. So we can see that the primary fissure separates the anterior and posterior lobes, and then the posterolateral fissure separates the cerebellum here from the flocculonodular lobe. The flocculonodular lobe has this nodule in midline and then this flocculus out laterally. And then there's a vermis medially and a paravermis outside of it, and then the cerebellar hemispheres. So now the modules. So first, the oldest phylogenetic module, the vestibulocerebellum or arc cerebellum. It encompasses the flocculonodular lobe and then also this anterior tip of the vermis and the lingula. It produces orientation in space, so equilibrium and eye movements. So even if we don't have visual input, we can have orientation of space because of this portion of the cerebellum. If it's affected, if it's injured, the main physical exam finding is going to be nystagmus. And then from a symptomatic standpoint, we're going to have nausea and vomiting and vertigo secondary to injury. Spinocerebellum, this vermis, paravermis in the posterior lobe and then the anterior lobe is key for postural stability. So the key clinical manifestation of injury then is truncal ataxia. When we stand up, we're unable to stand upright because we don't have this postural stability. Then the newest phylogenetic region of the cerebellum is the pontocerebellum, this lateral posterior lobe here, this hemisphere. It produces fine motor movement, and the main manifestation of injury is incoordination with an inability to do finger-to-nose testing on exam. There's a lot of ataxia with finger-to-nose testing. It gets this pontocerebellar name because its main afferent input is from the pons. So efferent motor innervation comes from the cerebral cortex, innervates the pons, and then the pons sends information to the cerebellum for modulation, which then the cerebellum sends out to CNS targets. Key clinical correlations: acute alcohol intoxication is going to affect the entire cerebellum, so all three modules will be affected. So patients who are inebriated will display nystagmus, truncal ataxia, and then they'll have incoordination. And on exam testing, finger-to-nose testing is going to demonstrate ataxia. In contrast, chronic alcoholic cerebellar degeneration affects the spinocerebellum, so truncal ataxia is the key singular motor manifestation of chronic alcoholic cerebellar degeneration. The somatotopic map of the cerebellum is such that the legs and trunk lie in midline, whereas the arms are out lateral. This is really important for physical exam testing because if the patient is just laying in bed and you only do finger-to-nose testing, you're only assessing the hemisphere itself. You're not assessing this more midline region. So you have to get the patient up out of bed and assess their gait in order to assess for truncal ataxia. The other key thing is that the innervation itself is ipsilateral. So the majority of innervation is contralateral when it comes to neuroanatomy in the brain. But when it comes to the cerebellum, if the right cerebellar hemisphere is affected, then the right side of the body is going to have the display of injury, the incoordination. Cerebellar histology and circuitry, just some key points here. Here's one of these folium. We saw how those folia allow the cerebellum to pack densely into the posterior fossa. And there are these different layers, the molecular layer, Purkinje internal to it, and then the granule cell layer. And then there's these deep cerebellar nuclei. There's various mnemonics we can use to remember them, but from lateral to medial, don't eat greasy food for dentate, emboliform, globose, and vestigial nuclei. This is just a representation of the Purkinje cell itself. And then we have this cerebellar circuitry here. Complicated circuitry you can walk through in the tutorial on the site, but I just want to point out a couple key things. The first is that the inferior olivary nucleus sends climbing fibers up, and each Purkinje cell is innervated by a single climbing fiber. That's a high-yield board topic. And then the other thing is that these Purkinje cells have GABAergic inhibition of the deep cerebellar nuclei. Remember, we said the deep cerebellar nuclei have this glutamatergic efferent innervation of CNS targets. So that's just some high yield information on cerebellar anatomy.